Good morning, respected investigators of VML Phase 2 study. So, can we begin the session because it's already 11:33. So, I hope all of you have joined. So, Dr. Ketan. So, I welcome you all for this discussion on Ceftazidime, avibactam, Aztreonam Synergy testing subgroup study of VML Phase 2. And basically, we have gathered those institutes who have shown interest via Google form to participate in this subgroup study. And we had a short discussion on the same topic last time, but this is a specific discussion where we'll be discussing the same things in a more elaborative way. We'll try to address the procurement issues, how institutes are planning to get the procurement, what are the needs for additional procurement, what we do out of box from our routine study. So, Sasi, are you there? Or anyone from our VMR team?
Yes, sir.
Yes.
Yeah, so how we'll go ahead is first we'll have introduction from the institutes.
Yes,
and Sasi, you'll be you open the Excel sheet, you share the Excel sheet with them,
Okay,
and it's sort of we'll have a informal attendance or something like that, so that we'll see how institutes have joined who had already participated in shown their interest in the study. Then we'll begin our discussion with Dr. Parth.
Okay, sir.
So can you share your Excel screen
Okay, sure.
having the list of
Sir, is this screen visible?
yeah, is visible.
Oh.
Okay, so let's create an additional column somewhere by the side of the name, maybe after C or by D somewhere.
Yes, sir.
Okay, so this is the list, but we have got for showing the interest for this synergy study, CZATM synergy study. So do we have any representation from NRI Medical College and General Hospital? Uma ma'am or someone?
Yes, sir, I'm present, sir.
Yeah, okay. Okay, ma'am. Anyone from NHL Municipal Medical College, Ahmedabad? Nasruddin, sir?
Yes, sir. So I'm. Yeah.
Thank you, sir.
Okay.
Anyone from Sri Satya Sai Assured of
Sir, present, sir.
Higher Medical
Dr. Hema.
Okay, okay. Thank you, Hema ma'am. Aster, Dr. Sumit. Someone from Aster Aadhar Hospital? Okay. Someone from Perfect Diagnostics, Dr. Frenil. Okay. Russell being, yeah.
Yeah.
Oh, yeah.
This
Hi,
is Dr.
Sumit.
Sumit. Yeah.
Sumit. Will.
Hello.
Russell Ben. Yeah, I got it. You, Dr. Sumit. Thank you. Someone from Russell Ben, Sevantilal Venus Hospital, Dr. Frenil.
Sir, all the three are the same doctor.
Yes.
Perfect, Venus Hospital, and Soros.
Okay, so Dr. Frenil, he's looking into one hospital and two diagnostic laboratories. So he's not there with us. Okay, a regional care center, Thiruvananthapuram, Dr. Sagila.
Present.
Yo, ma'am. Okay. Sure, ma'am. Sunita ma'am from Apollo Hospitals.
Yes, I'm present.
Yeah, okay. Thank you, ma'am. Breach Candy, Aruna ma'am, or someone from Breach Candy. Okay, AMU Aligarh, Fatima ma'am. Okay, then KIMS Kondapur Hyderabad, Dr. Mani.
Right. Thank you.
Okay, then DY Patil, Sajad sir.
Sir, I think it was Supriya ma'am from Breach Candy.
Okay, ma'am, are you there? Ma'am responded.
Yes,
Yes, sir.
Okay. DY Patil Medical College, Dr. Sajad sir. Okay, KG Somaiya Medical College, Dr. Moha
Yes,
Trivedi ma'am. Yeah, sure. Okay, Sri Venkateswara, Tirupati, Dr. Jayaprada ma'am. Okay, Great Eastern Medical School of and Hospitals, Dr. P. Samata.
Yes, sir.
Okay, thank you. Then NRI Medical College and General Hospital. That is the same. I think it's a repeat name. We'll remove that. Or maybe it's a repeat Google form. We remove that. Then PLS, so it's Margaret. It's Partha only.
Partha, sir.
Then SVS Medical College, Dr. Ramavat Usta ma'am. Okay, then we have Ruksamben, Deepchand Gagi Medical College, Ujjain, Dr. Yogyata. Care Hospitals, Visakhapatnam, Dr. Gayatri, or anyone
Yes, sir.
from that
Present.
institution?
Present, sir.
Okay, thank you. Okay, then Balco Medical Center, Raipur, Dr. Sristha. Okay, VPS Lakeshore Hospital, Dr. Tanya.
Yes.
Go down.
Yes, sir.
Okay, Dr. Tanya is there. Okay, Gyms, Greater Noida, Dr. Sneha.
Yes, sir.
Okay, thank you. Then Kamaini, Academy of Medical Sciences. Dr. Ridhi has joined from Ruksami Ben. That will mark. It's 23 number row.
Yes, sir. Marked.
Kamaini Academy, Lakshmi ma'am. Okay, we'll go down.
I think
St.
Dr.
John's,
Patel has joined, sir.
Savita Nagaraj.
Yes, sir. Good morning. This is Dr. Supriya, who is representing from St. John's. I want to correct, I'm not from Bridge Candy, but I'm from St. John's Medical College.
Yes, ma'am.
Okay. Then we have Kingway Hospital, Dr. Anuradha, ma'am.
Right.
Ma'am is there, I think. Then Kukilaban, Dhirubhai Dr. Poonam, ma'am. Kailas Hospital, Delhi, Dr. Sonali. I think D.Y. Patil is the repeat. We had D.Y. Patil in 16 row. You delete it. Okay, AIMS Bhatinda. Anyone from AIMS Bhatinda?
Yes, sir. I'm Dr. Bhavna from AIMS Bhatinda.
Okay, thank you, ma'am.
Sir, excuse me, sir. Myself,
Yeah,
Dr.
please.
Pranil Munim. Dr. Pranil Munim. I have
Okay,
joined
you'll be,
for all the three centers, sir.
you'll be representing all the three centers?
Yes,
Okay.
yes, yes.
Then we have Institute of Medical Sciences, some hospital, Dr. Pragna.
Yes, yes. Pragya. Dr. Pragya.
Okay, Pragya, ma'am. Thank you. Then ESI KK Nagar. Someone from ESI KK Nagar, Chennai. ESI Hyderabad, Manisha ma'am, or someone else?
Yeah, present, sir.
Okay, thank you. Then Chitranjan National Cancer Institute, Dr. Subransu. Narayana Multi-Speciality Hospital, Dr. Rupika ma'am.
Yes, I'm present.
Okay, thank you. Then we have NHL Municipal Medical College, Ahmedabad. That is
Sir,
repeat, I think.
repeat. Is it repeating, sir? Already had exam.
So I'll just tell the names which have responded just once quickly. We didn't get any response from Breach Candy. We didn't get any response from AMU Aligarh. We didn't get any
Dr.
response from
Ketan?
KIMS. Yes, ma'am.
Dr. Ketan, Dr. Sina, you're from Bridge
Oh, yeah.
Candy, VMR
Okay,
15.
you mark it. Yeah. Thank you, ma'am. Yeah.
Okay, thank you. Thank you.
Someone from AMU Aligarh. KIMS Hyderabad. Then D.Y. Patil. Then Sri Venkateswara Tripurati. Then Kamaini Academy. Okay, we got a response from Sri Jayadeva. Sri Jayadeva, which number we have? Just look, this is Sri Jayadeva Institute. Which one is Sri Jayadeva? VMR 28.
So,
okay, VMR 28 is not there. We'll write it down. Just write it down. Ma'am, you have not responded with the Google spreadsheet. We're marking your here. We request you kindly fill the Google spreadsheet also at the end of this discussion. VMR 28. In short, you write Sri Jayadeva. Later on, ma'am will pen fill and will. Okay, we didn't get any response from Chitranjan National Cancer Institute. Nothing from ESI KK Nagar, Chennai. Go up, Sasi. Okay, Kailas Hospital, Delhi. Kokilaban Hospital, Navi Mumbai. That's it. Okay, any other institute representative who have joined for the meeting and may would like willing to participate or in the subgroup study, this CSLA ATM synergy testing, who are not marked in the, can say their VMR code?
Yes, sir.
Institute name?
VMR 62 Apollo Hospital, Bilaspur. I'm Dr. Ekta
Just
Agrawal.
see you mark on the down. VMR 66?
62, sir. 62 Apollo Hospitals, Bilaspur.
60. Dr. Ekta Agrawal.
Ji.
Okay, anyone else who has not filled Google spreadsheet and have joined with us and are interested to participate in this subgroup study? I think that's it. Those who will join late may mark their presence later on. So now we'll start with our discussion of this subgroup study. I would request Dr. Parth to
Yeah, thank you.
join with us and I can see Poonam ma'am joining.
Yes.
Okay, so Stacy, you mark Kokilaben as present.
Ketan, myself present, Dr. Kumudini, KIMS, Kalinga Institute of Medical Sciences, 31 BMR.
Okay, Stacy, you mark that ma'am as present.
Okay, thank you.
Thank you, ma'am.
Okay, my screen is visible, Ketan?
Yes. Your slides now, yeah.
Slides are changing?
Yes, they're changing.
Okay, good morning, everyone. So we'll be starting the discussion on the subgroup study. This is subgroup study number 1, Ceftazidime, avibactam. Ceftazidime, avibactam and Aztreonam Synergy study by broth, disc, elution, and e-test. So we have set our study title as evaluation of in vitro synergy between Aztreonam and Ceftazidime avibactam among the clinical isolate of carbapenem resistant enterobacterials in order to aid in deciding on its combination therapy. The primary objective will be to estimate the in vitro synergy between the Aztreonam and Ceftazidime avibactam among the clinical isolate of CRE, and secondary will be to evaluate the disc elution method of synergy testing as compared to the various other methods, and to evaluate the role of synergy among the various type of carbapenems producing enterobacterials. Now coming to the rationale behind the combination therapy. As we know that as per the Amler classification, we have 4 different classes of carbapenems, 4 different classes of beta-lactamases. Class A, under class A, we have ESBL and KPC producer. Under class B, we have MBL or metallo-beta-lactamases, which include NDM, VIM, and IMP. Class C, we have AMC beta-lactamases, and class D, we have oxacillinases like OXA48, like etc. So, ceftazidime avibactam, the active component is the avibactam. The avibactam are implies class A, class B, class C, and class D, but it cannot neutralize class B beta-lactamases, which is MBL. Okay, so on the other hand, we have monobactam, that is Aztreonam. Surprisingly, that is stable. That is stable in presence of MBL. So it is able to neutralize MBL effectively. So what we are concerned more about the MBL, those are usually present with other beta-lactamases like ESBL or AMC. So co-expression of those ESBL, AMC, other beta-lactamases are very common in MBL producer. So that is an area of challenge for us. So that's why we need to have a combination of therapy which can take care of both the MBL as well as the co-producer like ESBL and AMC. So there is the role of the use of combination therapy of ceftazidime avibactam with Aztreonam. The later one is effective against combating the MBLs. So there was no proven method to demonstrate the synergy between the ceftazidime avibactam and Aztreonam till 2022, when ICMR came up with the guidance stating the 4 different methods like disc stacking, e-test stacking, crisscross method. Those are the methods which was recommended by ICMR in 2022. In 2024, the CLSI has approved broth disc elution test to demonstrate the synergy between ceftazidime avibactam and Aztreonam. So that will be our gold standard. So hence the use of broth disc elution test as a gold standard, and if possible, you can do the other way of synergy demonstration by strip stacking or strip crisscross, or you can do this stacking method. We will be discussing one by one in detail. So this is our inclusion criteria is all the carbapenem resistant enterobacterial obtained from the culture of any clinical specimen such as blood, urine, respiratory specimen, and exudate samples will be taken for the study. And if any carbapenem is flagged resistance by the automated system, so it can be ertapenem, imipenem, or meropenem, any one or more than one, will take those isolate, will include those isolate for the study. Now coming to the carbapenem, the testing of carbapenem as we do in our routine clinical practice from the clinical specimen using the Vitek 2 GN AST card. So if you are using 405, you'll be able to get the MIC of imipenem, meropenem, and ertapenem. If you are using 406 for any NLF E. coli, so you'll be able to get the imipenem, meropenem MIC. Optional secondary testing by carbubar dust diffusion method. The definition of carbapenem resistance for our study, we have set it the resistance to any one of the carbapenem tested in the N405 or 406 panel. So here are the three essentials part of the study. So what you need to do here. So basically 3 different things we need to perform in our study. One is the testing the AST of Ceftazidime avibactam, testing the AST of Aztreonam, and testing the synergy of avibactam and Aztreonam. We have kept optional, although we have kept it optional, but our group recommends the center to perform the CRE detection. CRE detection by any of the phenotypic, CLSI recommended phenotypic or genotypic method. I'll be discussing those later in detail. But we are encouraging the center to go for carbapenem production test, because unless and until you get to know that which carbapenem gene is present in the isolate, you may not able to go for definitive therapy by doing the synergy test. So here, so what we have, this is the testing of AST for Ceftazidime avibactam. So the compulsory method we have kept dust diffusion, carbubar dust diffusion. You need to use 30 by 20 microgram of Ceftazidime avibactam. Well, you want to use 10 by 4 microgram disc, which is recommended by UPAST. Okay, we are following the CLSI, which states using Ceftazidime avibactam at a concentration of 30 by 20 microgram. Okay, so the other optional things are you can get the MIC of Ceftazidime avibactam if you're using 407 card, there's a critical care card, or by using the e-test strip of Ceftazidime avibactam, or by performing the broth microinfusion test of Ceftazidime avibactam. And at the end of the incubation, the zone diameter is interpreted, or MIC is interpreted as per the CLSI breakpoint, as you can see in table number 2A1. Where the disc contained is 30 by 20 microgram. The zone diameter is less than equal to 20 is considered to be resistant, and more than equal to 21 is considered to be sensitive. In case of MIC, it's less sensitive, more than 16 is resistant. Important to note here that confirmatory MIC testing is indicated of the isolate with zone of with zone between 20 to 22 millimeters to avoid any reporting false susceptible or false resistant result. So we are encouraging the center, if you come across with the zone diameter of between 20 to 22, better to go for MIC to verify. Now coming to the AST testing of Aztreonam, again we are recommending the compulsory one is by dust diffusion, carbubar dust diffusion method, where we are using 30 microgram Aztreonam disc as recommended by CLSI. Optional are you can get the MIC of Aztreonam by using if you're using 406, or by using the easy test, or by broth microdilution. So this is the CLSI table taken from the CLSI 2A1, where you can see the Aztreonam breakpoints, clinical breakpoints. Less than equal to 4 is in sensitive, 8 intermediate, more than equal to 16 is resistant. If you go for the diffusion test, then less than 17 millimeter is considered to be sensitive, 18 to 20 intermediate, and more than equal to 21 is considered to be resistant. Sensitive. Now coming to the third of the study, there is a synergy between the Ceftazidime and Aztreonam. The CLSI in 2022 has come up with the broth disc elution test, which is recommended by CLSI and will be the gold standard for our study. That is a must for all the centers to perform synergy test for Ceftazidime avibactam. So CLSI recommends it to do for enterobacterials and Stenotrophomonas maltophilia, and they are recommending this test to be done for multi-drug resistant isolate, especially the MBL producer. So what you will be needing for the test, you need to have 4 screw cap glass bottle containing 5 ml of cation adjusted Muller-Hilton broth, and you need to have 1 each of Ceftazidime avibactam and 2 each of Ceftazidime avibactam disc, of concentration, which I mentioned before. So after you add the disk, as you can see, the final concentration of Aztreonam will be 30 by 5, so 6 microgram per ml. And for ceftazidime avibactam, it will be say 30 by 5, again 6. For avibactam, it will be 20 by 5, 4 microgram per ml. So how to perform the test? As you can see, you need to have 4 screw-capped glass tubes, okay, with flat bottom. Okay, that the detail of procurement will be discussing at the end of the session. Okay, so you need to label it as GC, that is a growth control, ATM, Aztreonam, CZA, ceftazidime avibactam, and ATM plus CZA. So first you mark that, and then aseptically you have to add 1 Aztreonam disk into the tube written as ATM, 1 CZA disk to the tube labeled as CZA, and 1 each of Aztreonam and CZA tube labeled as ATM plus CZA. And you have to gently vortex it after addition of the disk, so that the antimicrobial elutes from the disk for at least 30 minutes. So you have to incubate at room temperature for 30 minutes, but not more than 60 minutes. After that, you have to prepare the standard inoculum. You have to prepare 0.5 McFarland, and you have to transfer 25 microliter of the standardized inoculum into the growth ATM CZA and ATM plus CZA tube to attain the final inoculum concentration of 7.5 into 10 to the power 5 CFU per ml. And now you have to do a backup subculture to check for the sterility into the blood agar plate from each tube. Now, what you need to do, you have to tighten the cap, and you have to vortex. You have to vortex so that it mixes thoroughly. The inoculum mixes thoroughly with the disk. Following that, you have to loosen the cap before putting it for the incubation. You have to incubate it overnight at 33 to 35 degrees centigrade for 16 to 20 hours. After the end of incubation, you have to check the tubes visually to look for any growth or no growth. So what you need to check, your GC tube, first you need to check. So there should be a presence of turbidity in your GC tube for the test to be interpreted subsequently. After that, you need to check the ATM, CZA, and ATM plus CZA tube for growth or no growth. So any turbidity is there present in any of the tube is considered to be, needs to be reported as growth. And if there is no growth, it should be interpreted as. So if there is presence of any growth, then non-susceptible. If there is presence of no growth, you have to report it as or interpret it as susceptible. Now you have to perform QC. You have to perform QC weekly. You have kept it weekly for CZA, Aztreonam separately, as you will be doing this diffusion. That we made compulsory for each center. And do QC for Ceftazidime avibactam Synergy. So for Ceftazidime avibactam QC, although the CLSI recommends using Klebsiella pneumoniae ATCC 700603, but we have kept it easy for the center. We can use either of the E. coli, the ATCC 25922 or Pseudomonas aeruginosa ATCC 27853. So as you can see, the zone diameter range is given 27 to 35 for ATCC if you're using ATCC E. coli to check for the QC of CZA, or the zone diameter range is 25 to 31 for Pseudomonas if you are using Pseudomonas aeruginosa ATCC. But the recommended one is the Klebsiella. For our study, we have kept it simple. You have to just use 25922. Same is for Ceftazidime avibactam MIC. So the range, as you can see, 0.06 to 0.5 if you're using ATCC E. coli 25922. Again, the recommended one is the Klebsiella pneumoniae 700603, where the MIC range is 0.25 to 2. Now coming to the Aztreonam QC. So using the Aztreonam 30 microgram disk, again, we have kept it simple. Only you can use E. coli 25922, where the range is given. If you're using this diffusion, the zone diameter range is between 28 to 36. Or if you're using MIC based method, the MIC range is between 0.06 to 0.5. If you're using ATCC E. coli 25922. Now coming for the QC of Ceftazidime avibactam Synergy, although there's a long list given in to check for the different strains, the non-CRE strain, we have kept it mandatory, compulsory for all the center. So you have to use only 25922, where this is non-CRE, so you'll be expecting no growth in all the 3 tubes. ATM CZA and Aztreonam plus CZA. So those all three are susceptible. Now, if you can check the other CLSI recommended ATCC, Klebsiella pneumoniae BA1705, that is mainly for KPC producer. Okay, because here you can see the Aztreonam non-susceptible in only in Aztreonam because of the co-production of the ESBL. The Aztreonam tube will show growth, but CZA and combination of CZA Aztreonam will show no growth. Okay, same is applicable for 2146. ATC, Klebsiella pneumoniae ATCC 2146, which is actually meant for NDM producing strain. As you can see, there will be presence of growth in ATM and CZA tube individually, but there is no growth in combined CZA plus Aztreonam. And the last one is E. coli AR bank 0348. This is a strain which is procured which is being maintained in CDC in collaboration with FDA. Okay, and this is a extensively resistant strain. So you'll be expecting growth in all the three tubes. So we made you compulsory only to perform E. coli 25922. Okay, for QC of weekly QC of Ceftazidime avibactam Synergy. Same E. coli 25922 can be used for individual quality check of Ceftazidime avibactam and Aztreonam also. Now coming to the interpretation, so at the end of doing this all three steps, so you'll be having CZA, Aztreonam, this diffusion or MIC value in your hand, along with the result of CZA Aztreonam. So the table is showing different troubleshooting, different situation which you may come across during the study. So if you are getting no growth in all the three tubes,
very easy thing, ma'am. That yes.
Can you mute
Sometimes.
yourself, Dr.
Yes.
Poonam? Yeah. So if you can come across with different scenario, like if you're getting no growth in any of the three tubes, then your synergy may be present. If you're getting growth in any of the two tubes between ATM and CZA, but no growth for CZA Aztreonam tube, then also synergy is present. If you're getting growth in ATM and CZA tube individually, but there is no growth, synergy is definitely present. Okay, so which will be getting in most of our clinical isolate, which produces NDM. And if you are getting growth in combination antibiotic tube, that means CZA plus Aztreonam, but there is no growth in either of the Aztreonam and CZA tube, as you can see. So there is an error. So you have to suspect there must be some error, because here your combination antibiotic will be showing growth, but you may come across the other situation that your CZA and Aztreonam tube show no growth, or any of the tube show growth. Okay, there must be some error in your test. So you have to repeat synergy in these scenarios. Okay, now the other situation you may come across, because you'll be having your individual diffusion or MIC data in hand for your Ceftazidime and Aztreonam, and your Ceftazidime, avibactam and Aztreonam disillusion test result. So if you are getting now the next scenario is, if you are getting concordant result with your Ceftazidime avibactam diffusion and your Ceftazidime avibactam disillusion tube test, then your result is fine, test is okay. But if there is a discrepancy between the diffusion, the interpretation of your CZA and CZA tube result under disillusion test, then there must be some error. So it is vice versa. So there is suspected error. So you have to repeat the CZA testing in that case. On the other hand, if you may come across another situation where the Aztreonam, there is a discordance between the Aztreonam diffusion interpretation and your Aztreonam tube test interpretation under disillusion test. In that case also, there must be some error. So you need to repeat Aztreonam testing in those cases. Okay. So these are the different troubleshooting which you may come across during your day-to-day study of this Ceftazidime avibactam Synergy study, sub-study. So you have to deal accordingly. So please remember, when you're getting growth in the Aztreonam and CZA test tube, but no growth in either of the CZA and Aztreonam tube, then there must be some error. Or if there is discordance between your individual CZA or Aztreonam disk diffusion interpretation with your disk elution test result, then you have to repeat the test respectively. So wherever you will be getting discordance in a particular antibiotic, be it ceftazidime, avibactam or Aztreonam, so at that level you have to compare and you have to take a call whether you need to repeat the test or you should go ahead. So the results of error may be the contamination. So we are encouraging the centers to procure the screw cap glass tube with flat bottom. Okay, please don't use the glass tubes with cotton plug, which may lead to contamination. And improve, or the second scenario may be improper and concentration of the antibiotic used in the tube or error in the tube inoculum. So those are the important scenario which may lead to contamination or error in testing. So these are the alternate method of demonstration of synergy which you may perform at your laboratory. Okay, we encourage you to perform at least one other than the gold standard broad disk elution test, so that if you do more method, at the end of the study we can compare with the different method of synergy and we can come in conclusion which one is the best or which one is we can compare at the end of the study. So we are encouraging you to do at least one or more synergy study or synergy test in addition to your broad disk elution test. So the other methods as recommended by CLSI, as recommended by ICMR guidance in 2022, one of the method is ceftazidime avibactam E test. And using ceftazidime avibactam E test and Aztreonam E test, the method names are strip stacking method, perpendicular or crisscross strip method, and adjacent strip method. Those are the three different methods where these tests of ceftazidime avibactam and Aztreonam are being used. The second method is the using modified strip and Aztreonam disk, and the third method is using ceftazidime avibactam and Aztreonam disk method. Okay. So those are the methods which are recommended by ICMR in its guidance on diagnosis and management of carbapenem-resistant gram-negative infection in 2022.
I'd just like to add one point that let's try to understand what is the basic concept of this synergy testing. So basic concept is at a fixed concentration that of that is 4 microgram per ml. While you are doing a synergy testing, your avibactam, your Aztreonam ATM should cross susceptible breakpoint. Okay, this is the basic of synergy testing. So there are two parts of synergy testing. One part is mere demonstration of synergy, that some synergy has, and the other point is a significant synergy has occurred or not. Significant synergy can be ascertained only when in the presence of avibactam 4 microgram per ml, your Aztreonam is crossing the susceptible breakpoint. This is the rule. Now try to understand how in disk elution, how disk elution test was validated. Dr. Partha has already told, when you add one disk in each, the concentration of avibactam which is reached in each tube is basically our disk is having 30-20. So if you dilute it in 5 ml, the concentration of avibactam becomes 4 microgram per ml. So this is a fixed concentration. This concentration holds true for MBD testing, E-test testing, as well as disk testing. The avibactam concentration at synergy testing should be constant 4 microgram per ml. Now, what about disk elution? Why I'm telling you this now? Because this will help you understand the interpretation of these testing methodologies, what you may be doing or are doing currently in your setup. So let's talk about disk elution. Disk elution with 30 microgram ATM disk is being used. When we dilute it with 5 ml of CMHB, the concentration what we get is 6 microgram per ml. Once it is in the tube of ATM, if we see a no growth, that means the MIC must be 6 or less. What is the breakpoint for ATM? Breakpoint is 8 microgram per ml. So a no growth in the synergy tube or a no growth in the ATM tube denotes that the MIC of Aztreonam has fallen below 6. That is, 8 is being the susceptible breakpoint. It can assume that ATM synergy ATM MIC has been reduced below 8. Now the same interpretation is to be used when you use a double E-strip method or a ATM disk method. That I'll try to explain you when we'll see the picture. Partha, can we go to the next picture?
Yeah. And one more thing I just would like to add on.
You explain the method, I'll tell the principle then.
Yeah. So the thing is only it has kept the concentration has kept, as Ketan told, 4 microgram per ml. That is close to the serum nadir of avibactam, 2.2 microgram per ml. So the basic idea of keeping that concentration above the or close to the serum nadir helps to help you to interpret when you are using when you are using Aztreonam along with fixed dose concentration of avibactam in Czd.
Yes.
So this is the first method. This is the gradient strip stacking method, the first one, where you have to do the lawn culture of your suspected CRE organism. You have to make 0.5 McFarlane and do the lawn culture and place the Aztreonam E strip for 10 minutes. And then the Aztreonam E strip is removed. And in the same place, you have to place Ceftazidime avibactam E strip in the same position. And after that, you have to replace the Aztreonam E strip over the Ceftazidime avibactam E strip and incubate overnight at 37 degrees. So after overnight incubation, you need to check for the elliptical zone of inhibition where it intersects the Aztreonam scale. So here at Aztreonam, in presence of fixed dose combination of avibactam, that is 4 microgram per ml in Czd strip, it is able to demonstrate sensitivity or not. Okay, so that is our main motto. So if the Aztreonam MIC is less than 8, in this case, it is 1, as you can see in the picture. So in presence of CZA, it is showing synergy. Okay, the same.
One thing is that this is the recommended isomer method, but it is to enhance the sensitivity. If you're low on E strip count and you still want to do a E strip stacking method, then I believe these two are the compulsory methods. And this is to enhance your sensitivity, because once you stack E strip over, so what is done is CZA strip is first placed, and above CZA strip we place the ATM strip. What can go wrong is the diffusion of ATM strip now will be compromised because it is placed above a CZA strip. So to take care of this error, the additional step introduces you first only make your Aztreonam diffuse into the media, and then you extra take care of that by putting the Aztreonam again on the CZA strip. What is happening is from the CZA strip, the avibactam 4 microgram. This strip is also having avibactam constant 4 microgram. So once you place the CZA strip, the media will be having microgram per ml of constant avibactam in the media. Then when the Aztreonam diffuses out, if you get synergy, like Dr. Partha told, that you have to read this MIC as per the MIC of Aztreonam mentioned in CLSI. 8, 16, and 32. So if it should cross the MIC of Aztreonam to tell that the synergy is going to work actually. So if you're low on E-test, even if it's not a recommended method, you can still work around with these two. And if only you are low on E-strip and you still want to do a E-strip stacking method, this Aztreonam E-test can be omitted, but these two are the compulsory one. But this is my personal view.
Yeah, because this method of synergy gives excellent result. When you will be start doing and comparing this dilution along with the strip stack, get to know that these are the most of the cases it gives concordant result. These two method I'm talking about. And one more thing, that sensitive and the intermediate sensitive breakpoints, those both can be considered as susceptible. Right, Ketan?
Yes.
So 8 or 16. So if you get 8 or less than 8 MIC, if you come across 16 MIC of Aztreonam, both should be considered as susceptible in case of interpreting Aztreonam and avibactam synergy test. So both the things you should keep under consideration. Okay, so if you get 16 MIC of Aztreonam in your strip stacking method, you should also consider it as synergy positive. Because the basic funda is you need to check for the Aztreonam MIC if it is susceptible or intermediate susceptible in presence of fixed dose combination of avibactam in CZA. So that is the idea behind the each methodology. So the second one is the modified E-test disk method, where you can see the second method is the crisscross method, where after the lawn culture you have to place the Aztreonam test, and at the intermediate susceptible breakpoint of Aztreonam, that is the 16, you have to place the CZA perpendicular to the Aztreonam test. And at the end of the incubation, you have to see the elliptical zone of inhibition where it intersects the Aztreonam MIC strip is the MIC of the Aztreonam, and you have to interpret as per the CLSI breakpoint. Okay. Another
So
method of
basically,
doing the synergy test.
you will be wondering why this crisscross perpendicular method is devised. So basically, as Dr. Parth told, that we place it at the intermediate MIC of Aztreonam. This is Aztreonam, and this is CZA. So why this methodology is like that? So the avibactam will diffuse on either side from the CZA E strip. Now, it's very easy to interpret because your I and S are in this direction, your R is in this direction. So if your ellipse closes before the CZA strip, it is taken as synergy positive because Aztreonam I is here. So I and S are on this side. So if your ellipse closes by the CZA strip, it is synergy present. If your ellipse crosses beyond the CZA strip, it means your ATM MIC is crossing beyond the I, synergy negative. So if you place it, the purpose of placing it exactly at I MIC of ATM is, it can be visually give you easy to read. If your ellipse crosses beyond this, something like this, synergy present. Something like this, synergy present. If it crosses beyond this E strip, synergy is not present. This gives you a very easy to read. If you do a side by side, you can use this for reading your CZA MIC, and you can use this intersection to read your synergy ATM MIC. You read this zone and use the ATM breakpoint to find out if synergy happened or didn't happen. Okay, Parth.
Okay. Okay. So these are the different synergy tests where you're using 2E strip. So we have already described the strip stacking, perpendicular strip, and distance strip method. The next method is the CZA disk stacking method using the CZA and ATM disk. So this is the modified e-test ATM disk method, where after doing the after lawn culture, you have to place the CZA e-test over the MHA plate, and from the sensitivity breakpoint of CZA, that is the 8, you have to place the 15 millimeter away from the sensitivity breakpoint of CZA. So from 8, you have to keep 15 millimeter distance, and you have to place the ATM strip over the MHA plate, and you have to incubate the plate overnight. So at the end of incubation, what you need to look for, you may come across different scenario. If your isolate is NBL producer, you may get inverse D. Inverse D, as you can see, it applies same like that of D test for your clindamycin, inducible clindamycin resistance. The same, you'll be getting the inverse D-shaped zone of inhibition towards CZA test. So that indicates synergy is positive. You may come across the next scenario where you'll be getting CZA sensitive MIC using the e-test, and as well as you'll be getting the synergy positive result, because around the you have to measure the radius here. You have to measure the radius of zone of inhibition on either side of the ATM disk, and you have to convert it into the zone diameter. So that is a quantitative method actually for demonstration of synergy. So that is another way of expressing the synergy positive in case of modified e-test desk method. And the fourth scenario where you'll be getting CZA is resistant and your synergy is also negative. And the fifth scenario is where you may come across Aztreonam is sensitive with zone diameter of more than sensitive breakpoint, and your CZA, your synergy is negative, as you can see. So different scenario you may come across. Okay, so it is basically in case of NDM, you may get inverse D shaped zone of inhibition. In case of OXA producer, you may get a sensitive MIC breakpoint for CZA, and your synergy is positive. And in case of other co-producer, or in case of other non-introbacterials, non-fermenter, you may come across the scenario where your synergy is negative and your Aztreonam may be negative, may be resistant or sensitive. So these are the different combination which you may come across in case of modified e-test desk ATM desk method. So this is now come to the disk stacking. So anyway, you have to perform the disk diffusion method for your Aztreonam and CZA. So what you need to have here for the disk, the stacking method, you have to get, you have to use 2 ATM disks and 2 CZA disks. Basically, as you are doing CZA and Aztreonam susceptibility separately, so you have to use here 1 CZA over Aztreonam and 1 Aztreonam over the CZA to check for the synergy. So in a single MHA plate, after doing down culture, you have to place 1 ATM single, 1 CZA single, and 1 CZA over ATM and 1 ATM over CZA. And you have to incubate overnight. After incubation, you have to look for the zone of inhibition. As you can see in the picture, there will be, in case of CRE isolate, in case of suspected Indian producer, there will be resistance of ATM and CZA individually, but positive result will get in case of combination of CZA over ATM or CZA ATM over CZA disk. So this is disk stacking. So before that, you have to add 20 microliter of saline. So after placing the disk, you have to apply 20 microliter of sterile saline over the double disk where you are putting double disk, because you have to, using the solution, saline solution, you are antibiotic into the media. So in case of CZA over Aztreonam, the CZA will diffuse through along with the Aztreonam into the media. And in case of Aztreonam over CZA, the Aztreonam will elute with the help of the saline along with CZA into the media. So at the end of incubation, you'll be getting zone of inhibition, larger zone of inhibition of Aztreonam and CZA. Okay, and that's give you energy. So this is all about your synergy, different synergy method. Now you're encouraging the center another to perform another test, because you need to know which carbapenemase you are dealing with, which carbapenemase gene are present in your clinical isolate. So
21486.
Dr. Supriya, can you unmute yourself? So can you mute yourself? So we make the MSIM and eSIM compulsory for demonstration of the carbapenemase production. Okay, as per the CLA, as it is a CLSI recommended method. Okay, so if you are having PCR in your setup, then you can go for resistant Enterobacter gene detection to detect this 5 carbapenemase gene, namely KPC, NDM, IMP, VIM, and OXA48 like. So you can go for, you can either go for real-time PCR, or if you are using conventional PCR, that is also accepted. But if you are using the alternatively, if you are using the closed system Gene Expert, so using the Expert Carba cartridge, you can also go for carbapenem gene test at your center if you are doing so. So those are all optional method. Although we have kept it optional, but we are encouraging the center to perform in any of this test at least MC-MESIM, in your center. Okay, if you are not having PCR setup. So I'll describe the MC-MESIM and other methodology in the subsequent slide. So this is the phenotypic table taken from the ICM-22. As you can see, these are the different phenotypic options available for demonstration of the carbapenemase. MSIM in combination with eSIM, it detects all 5 carbapenemase with more than 90% sensitivity and specificity. And eSIM, the purpose of putting eSIM along with the MSIM is to differentiate class B enzymes. So it helps to differentiate serine beta lactamases from lactamases, but the limitation is the turnaround time is long, around 18 to 24 hours, and it may not able to pick up class other when the class B, that is metallo-beta-lactamase co-expressed with class A or class D enzymes. That means KPC. If NDM with KPC or NDM with OXA, it may not able to pick those. Okay, well, it is recommended by CLSI. And another option is carbine P and rapidic carbine P. Carbine P is, but we are not going for carbine P because it again it will give financial burden to the center. But MC-MESIM are less costly. You have to just use the routine one disc, meropenem disc along with TSP. I'll be describing in detail. And the other method is NG Carba 5 test, which is a multiplex lateral flow immunoassay, which is easy to perform. It takes only 15 to 20 minutes time. Once you get the growth on the culture plate. Okay, it has a high sensitivity of 100% and sensitivity and specificity of 100% and rapid turnaround time of less than 15 minutes. And it is FDA approved. Okay, although it is not recommended by CLSI, but it fails to detect a certain carbapenemase gene like GES, ACM, SME, IMI. Those are also rare, but what we are dealing with, the main 5 carbapenemase be detected by this lateral flow assay. this lateral flow assay I'll be describing short in the each and every method of doing carbapenemase detection as per CLSI. The first one is MSIM only or in conjunction with the eSIM. MSIM stands for Modified Carbapenem Inactivation Method, and eSIM stands for EDTA Carbapenem Inactivation Method. Always MSIM need to be put along with the eSIM. May not able to differentiate metalloorbital lactamase from the serine carbapenemase. So, and another thing you have to remember, the MSIM can MSIM need to be positive before you interpret the result of eSIM, because it will give you the clue of carbapenemase production. So once the MSIM is positive, that means your isolate is carbapenemase producing, then you have to go for interpreting eSIM result, which helps to differentiate carbapenemase from the metalloorbital lactamases. Okay. Now, so what you need to have here, you need to have two meropenem disc. Okay, and then your loop 1 and 10 microliter loop, your nutrient broth or normal saline, 3 to 5 ml aliquots, then MHA plate and meropenem susceptible E. coli, ATCC 25922, and 5 molar EDTA. That is only needed for eSIM. So how to perform the test? You have to take the 2 tubes of containing 2 ml of tryptic soy broth, and using the what you have to do, you have to using the 1 ml loop, you have to take the loop full of the bacteria, for enterobacterials, and if you are taking isolate from the Pseudomonas colony, you have to use 10 microliter loop. You have to thoroughly vortex the tube for 10 to 15 minutes after addition, and after that you have to add 10 microgram meropenem disc into each tube. Okay, and ensure the entire disc is immersed into the suspension. Okay, and after that you have to incubate it for 35 degrees centigrade for 4 hours. Okay, so 4 hours is a must, minimum 4 hours plus minus 15 minutes you need to incubate. Okay, so before 4 hours completed, you have to do a lawn culture of you have to prepare the inoculum of 259 ATCC E. coli 25922, and you have to do the lawn culture on MHA plate. Okay, and you have to mark eSIM and MSIM. In using a single plate, you can do maximum 3 isolate subculture you can do. So you can divide and you can mark eSIM and MSIM on the back of the MHA plate, and you have to, what you need to do, you have to remove the disc, meropenem disc, from the respective tube that already you have marked as MSIM and eSIM. So you have to take the tube, you have to take the disc out, you have to draw against the wall of the tube, you have to draw take it out to remove the excess water, and you have to place the meropenem disc on the MHA agar plate where you have marked it as MSIM, and same need to be done in case of eSIM. But one extra step you need to perform in case of eSIM test, you have to add 20 microliter of 0.5 molar EDTA into the tube containing TSB. Okay, to get the final concentration of 5 millimole EDTA. Okay, and the rest of the steps are similar. So here you are adding up EDTA, you are checking whether in presence of EDTA your is able to neutralize your meropenem disc or not. So that is the main idea behind doing the carbapenem inactivation method, because your isolator is supposed to produce the carbapenemase. You are checking in presence or in absence of EDTA whether your isolate are able to hydrolyze the antibiotic disc or not. So how to see whether the disc has been neutralized or not? So you place those discs onto a media containing meropenem susceptible ATCC E. coli to check for the effectiveness of the disc remains active or it already got hydrolyzed. Okay. So at the end of incubation, how to interpret? This is very important. So first you need to take the reading of MSIM result. So you have to measure the zone of inhibition of disc. Okay, if it is between 6 to 15 millimeter, or if there is presence of pinpoint colony within 16 to 18 millimeter of zone of inhibition around the meropenem disc in MSIM, then that indicates there is a production of carbapenemase enzyme. Okay, then only you have to move forward to look for the eSIM result. Otherwise, if you get zone diameter of more than 9 millimeter, then the your isolate is non-CRE, non-carbapenemase producer. You are not supposed to go for taking the reading of eSIM. Okay, and if the zone of diameter is between 16 to 18, then you need to interpret as inconclusive. Okay, you have to repeat the test in that case. Then once you get your positive MSIM result, that is zone of inhibition of between 6 to 15, then only you have to go for taking the eSIM result. Okay, eSIM. So so you have to remember, you need to interpret only eSIM result when your MSIM result is positive for carbapenems. Positive means that indicates your isolate is carbapenems producer. Then how to interpret the eSIM result? If you are getting, for example, if you are getting no zone of inhibition around the MSIM, around the meropenem desk in case of MSIM, but you are getting a big zone of inhibition in case of eSIM, in case of desk, in case of meropenem desk, in case of eSIM result. So if you're getting a big zone of inhibition and the difference of zone of inhibition is more than 5 millimeter. So for example, if you're getting MSIM result 6 millimeter, there is no zone of inhibition. You are getting zone of inhibition of 15 millimeter in case of eSIM result around meropenem desk. So the difference between zone of inhibition is 15 minus 6, 9 millimeter. So it is more than 5. So more than 5 zone of difference of zone diameter between the eSIM and MSIM indicates your isolate is eSIM. You have to interpret as eSIM positive. That means your isolate is metallo-beta-lactamase producer. Okay, but if you're getting the difference, if the difference is less than 4 millimeter of zone diameter between eSIM and MSIM, your interpretation to will be eSIM negative. eSIM negative means here the option may be different. See, the another scenario is if you're getting MSIM and eSIM both, there is no zone of inhibition, then your interpretation will be setting carbapenems producer. So you may come across 3 different scenarios. As I told you, MSIM should be positive, means for carbapenems if you are getting a zone diameter of 6 to 15. If your MSIM is positive for carbapenems, then only you should go for interpreting eSIM result. Difference of zone of inhibition if more than 5 between eSIM and MSIM, then it is metal-beta-lactamase producer. If there is no zone of inhibition around the desk around the meropenem desk in case of eSIM and MSIM, then your result is serine carbapenems producer. So this is very simple test which you can do. It takes only overnight time. This is the only thing, but using the simple consumables which you are daily using in the lab, you can perform the test. The next one is the lateral flow assay using the NG test Carba5, which is a visual multiplex immunochromatographic assay for qualitative detection of and differentiation of KPC, OXA48, VIM, IMP, and NDM from carbapenem non-susceptible pure bacterial colonies. And the detection limit, as you can see, for KPC it is 600 picogram per ml. For OXA30, for OXA and VIM it is 300. IMP it is 200, and for NDM it is 150. And the sensitivity is around 100%. And many publications there where they have compared, even they have done directly from simulated blood culture sample to pick up the carbapenems gene using this lateral flow assay. Okay, I have inquired with the high media. The high media along with NG Biotech, they are providing this kit. Okay, so the cost is after discount, it will be around 1200. Okay, coming to the genotypic method, the various options are available. If your lab is doing open system RT-PCR, that will be the best option. As we are also doing in our lab, open system RT-PCR, the kit cost is less, around 500 to 600 per reaction. Okay, so there are many kits commercially available from True PCR CR detection kit, high PCR carbapenems probe detection kit from high media. So those are the commercially available kit. So you need to have amplification and DNA extraction kit. DNA extraction, you can use any CIVD approved kit. Preferred one definitely DNA mini kit, QIAM DNA mini kit from QIAGEN, or any CIVD approved DNA extraction kit can be used for. Then other than open system, we have closed system. Gene expert, then you have the option for using the expert carbar cartridge to detect this carbapenems gene. It takes around 2 hour time. You can do directly from the clinical isolate or directly from the sample, but here we are encouraging you to do it from the clinical isolate only. Okay, not from the sample directly. The sensitivity and specificity is around 100%, and the turnaround time of the test is 2 hours only. The cost is around I think it's 23 or 2400 per cartridge. Now the BioFire Flea array, but you need to have positive blood culture bottle flagged by the BACTEC. It can detect only KPC gene. Its turnaround time is 1 to 2 hours. It is CIVD and FDA approved. Okay. Now it'll be so this much. So what you need to do here is you perform the CZA and Aztreonam disk diffusion, that is compulsory. And you have to perform the broad disk elution test to demonstrate synergy as per CLSI and plus minus carbapenem detection method. Although we are encouraging you to perform CRE at your lab, either by genotypic or phenotypic method. Okay, if you don't have the sophisticated instrument, PCR instrument, if you can do simple MSIM and eSIM and just include the data in the study. So there will be a separate Google spreadsheet which will be providing with you, and you will have to enter certain data. Here your VMR code, the sample number, specimen, the organism name, and the Vitek AST result. So in addition to your carbapenem, so that is imipenem, meropenem, and artapenem, you have to enter the fourth generation of cefepime and third generation cephalosporin, ceftriaxone or ceftazidime. This result additional. And these are the additional information which you need, because the cefepime will help you to for AMC production. So it will give you the clue for AMC production and ceftazidime for ESBL production. So this why we are taking those extra information from you, because MBL often, as I told before, it has co-expressed with the other beta lactamases like ESBL. So ESBL and AMC are co-expressed with MBL most commonly. So at the end of the study, we may have data in our hand what percentage of isolate are having mixed or co-expressed enzyme data isolate, or which are the pure MBL one. Okay. Okay. So MBL, for MBL, we are using ATM. As you know, this is the active against MBL producing organism, and other things, the enzymes are taken care of by ceftazidime avibactam, the avibactam component of ceftazidime avibactam. So apart from that, what all the tests you have performed, you need to enter the data of that. So zone diameter or MIC value of CZA and Aztreonam separately. So you have to add. So you have to enter the zone diameter and its interpretation, and MIC value and its interpretation in the drop down will be provided. Okay, so you have to just enter the zone diameter in millimeter and interpretation as SI or R as per the CLSI Beckmont. Okay, same is applicable for MIC value. So the same holds true for Aztreonam also. So zone diameter, you have to add the zone diameter on MIC value. Okay, in the respective column. Then the CZA Aztreonam Synergy test by disk elution method, which is a compulsory one for you. So you have to enter the CZA Aztreonam and CZA plus Aztreonam growth or no growth. And in a separate column, you have to add the synergy interpretation, whether it is positive or negative. So individually, you have to enter the tube result if there is growth present or absent, and interpretation of synergy as positive or negative. The same holds true for CZA Aztreonam disk synergy by other method. If you are performing strip stacking or perpendicular strip method or disk stacking method, you have to enter the result if it is synergy positive or negative. That much is sufficient, present or absent. Okay. Now the last one is the carbapenemase detection method. So you can do either MSIM or eSIM, or by doing any genotypic or phenotypic method. Okay, so you have to enter the result, the MSIM positive, eSIM positive, or MSIM positive, eSIM negative. Okay, and the genotypic method, you have to mention the which particular method you are using in your lab, open system or closed system. Okay, and you have to enter the result if it is which particular gene you have detected by PCR among the 5 carbapenemase gene. So this is the data which you need to enter in the Google spreadsheet on a daily basis. At the end, using this Google spreadsheet, we'll analyze the data and publish. So this is the summary of tests which you need to do for the study. Compulsory one are the perform disk diffusion for ceftazidime avibactam and Aztreonam separately, and perform the CZA Aztreonam Synergy by CLSI recommended broad disk elution test. So these 2 are compulsory. Optional, we have kept perform CZA and Aztreonam susceptibility by any other method other than disk diffusion, and perform CZA Aztreonam Synergy by any other method, any method other than disk elution test. Okay, so it can be the strip stacking or perpendicular strip, or modified e-test disk method or strip stacking method. Okay, and the last option is the detection of carbapenemase by phenotypic and genotypic method, as I told. But we are encouraging you to perform this test, because unless and until you perform, you may not able to narrow down to the synergy for which particular isolate you need to perform synergy or not. But Here, in our case, we are performing synergy for all MDR isolate, including MBLs. So this is the summary of the desk, e-test, and other consumables which will be which you need to procure or you must be having in your lab. So as you know, for ceftazidime avibactam susceptibility by disk diffusion, you need to have only one CZ test and MHA plate. The same holds true for Aztreonam. Then for ceftazidime avibactam synergy broth disk dilution test, you need to have 2 each ceftazidime avibactam and Aztreonam disk, and 4 screw cap glass tube with 5 ml Ketan adjusted molar Hilton cloth. So we need to give emphasize on here that you need to procure better you need to procure screw cap glass tubes, because if you're using plain glass tube with cotton plug, it may lead to contamination. Okay, and Ketan adjusted molar Hilton you need to procure from high media. Okay. Then ceftazidime avibactam test for strip stacking or cross strip method. You have to procure 2. So 2 is strip, 1 each of CZA and Aztreonam is needed, along with MHA plate for strip stacking or cross strip method. For the modified CZA e-test and AT disk stacking, you need to have 2 each ATM and CZA, in addition to your CZA and Aztreonam susceptibility test, which you'll be doing in the same plate. So using a same plate, MHA plate, you'll be putting 1 CZA, 1 Aztreonam, as I told before. Along with that, 2 each of CZA and Aztreonam, one over another. Okay, to demonstrate the synergy. Now coming to the detection method for MCM and ECM, you need to have 2 meropenem discs to put this 2 tests parallel using 2 tubes containing 2 to 3 ml of TSB. You need to have 86 E. coli 25922 and 1 MHA plate where you can put maximum 3 isolate. For open system,
I'd like to add one thing, Dr. Parth. So basically, trypticase soy broth is what the Western literature suggests everywhere. It is the basal enriched media what they use. The problem is that our in Indian scenario, usually the basal broth what we use, enriched broth is BHI. Concept wise, I believe performing this test with BHI base or even nutrient base will not create any problem, because the basic thing what TSB is doing is allowing the organism to grow and diffusion of meropenem. So concept wise, using BHI or in place of trypticase soy broth, in case you don't have, makes sense.
Okay. So you have an alternate option of using this BHI if you don't have TSB in your lab. So other than that, if you are doing open system RT-PCR, then you have to procure the amplification and DNA extraction kit. If you are using closed system by GeneXpert, your GeneXpert machine and expert carbar cartridge you need to procure. So this is the summary of the consumable desk and e-test, which you may need to have while doing the study. Okay. So these are my reference. Now we'll open to all. If you have any doubt, you can ask any of us.
Initiating the procurement and specifying it is the most important part, because we have shown you the list of things what is required. You need to have CZA disk, you need to have Aztreonam disk. I believe Aztreonam disk everyone will be having, but arranging for CZA disk is something you must have to do. Screw cap, glass tubes, CMHB. If you already don't do broth microdilution in your setup, then you may have to work around for CMHB. So minimum procurement may CZA disk and CMHBs and glass tubes, screw cap glass tubes which are the basal requirement to even initiate participating in the study. Additionally, you can procure CZA E-strip, ATM E-strip, and other things day by day and start putting it. MC missing, like Dr. Parth already told, you just need a meropenem disc, an E. coli ATCC, which is present in all the institutes. I don't know any institute which is not having the E. coli ATCC common 125922. So it's easy to go ahead to initiate the study. At least CZA disc, and you must have a constant supply of CZA disc and constant supply of CMHB. If you're getting a CZA disc as a complementary from some institute that they keep doing it, you may not be able to participate in the study, because that's not a constant flow. It may get end over pretty soon, and then you'll be having no CZA. So to pick at least these 3 other requirements you must have. Yeah, open for questions.
Sir,
Yeah,
can
one
we
thing I
have,
just want to add that CZA disc, I think you must be getting FOC from Pfizer, most of the center. And the CZA e-test, which you need to buy from Biomeru, Okay. The thing is, we are in conversation with the Pfizer. Okay, I have initiated the process. Let's see how it goes on. If they can prove, if they can provide us the CZE test free of cost for this study. Okay, but again, we are not sure now. Okay, we have to. They have to also ask permission from the higher level, and if they agree to provide us in test free of cost, then that will be a great help for all the participating center. Okay, but at your end, if you're procuring, please continue procuring the CZE test from the Biomeru. Okay, because this is not sure whether they will be able to provide it in free of cost or not. Okay, so other than that, what other thing is mentioned in the table? At least what Dr. Ketan mentioned. So desk, e-test, and screw cap bottle and CA MHB. These are the minimum requirements to participate in the study. And again, we are encouraging you to do the CRE, to do the test which detects CR by any of the method. Minimum is MC. Now it's open for the forum. You can ask if you have any doubt.
Sir, first question might state that Pfizer, they already all formality they done, but they didn't supplied me the till date the CZ, and we procure by purchasing that. That is where the first thing. Second, my question is that, sir, in the disk staking method, you advise us to have the two staking, Aztreonam over the CZ and CZ over the Aztreonam. So two disk staking is costly affair. So would you please provide us the single option, 80 over the CZ or CZ over the 80? Does it makes the sense difference in the result also, sir? Kindly clarify, sir.
Yeah, actually, few articles have come up with this disk stacking with micro illusion method, which gives better result than only disk stacking. So the option is there whether you can put only CZA disk, only Aztreonam disk, and one CZA over Aztreonam. Okay, so that will give you the result. That will give you the result for synergy. But the better method is using two pair of CZA one over another and go for synergy demonstration after adding the, because that will give you the exact result, which because the study also showed that gives better result than only doing the disk stacking. Ketan,
Okay,
can we allow them to do only for disk stacking using a single CZA over Aztreonam?
Yeah, we can.
we can.
If they do it with one with disk stacking along with disk illusion, I think it will be acceptable for us.
Okay.
Thank you, sir.
Parth, hello, Dr. Sumit here.
Yeah.
Yes,
Hi,
Sumit.
Sumit.
Yeah, you have any clinical experience with using combination in a patient?
Yes. So
So
you're
how?
saying like combination therapy of CZA and Aztreonam. Yeah.
What
For last 2 years or so, you're using this methodology. You're doing the PCR, and we are detecting the carbapenemase gene. Okay, so in our setup, the most common one is NDM and followed by NDM and OXA co-producer. And in all the cases, we are putting this synergy test, and we are getting positive result in many of the, and using this combination therapy has markedly improved the patient clinical outcome.
What I feel is it's a urinary tract infection which is causing more good results. But for the critically ill patients within ICU, most probably the polymyxins are getting better than this combination, because the mortality, what I have seen is the mortality is more common with compared to polymyxins. What's your take on this? When the ET cultures are positive with the Klebsiella pneumoniae and all blood cultures are positive with means like CRE Klebsiellas.
Yes.
And we start with the Ceftazidime avibactam as a combination. It's even we are doing the synergy test for the last 6 to 8 months. Still.
See, the basic idea of doing this synergy, in vitro synergy, is to give you the whether this combination will work in vivo or not. But your synergy result positive doesn't mean always that it will work in vivo. Okay, so that is one point. And second point is doing synergy test without having idea of carbapenemase gene information again is of no use, because if you are able to at least differentiate if your isolates are metallo-beta-lactamase producer or senin-carbapenemase producer, you may go for therapy without waiting even for your gene detection result. Okay, but the thing is, gene detection is pretty more faster than MCME same result. And if you get to know that your isolate is NDM or NDM co-producer with OXA48, then you can start straightforward the combination therapy without waiting for synergy result, which will come up in the next day morning. So next day morning, by the time we'll inform the clinician about the synergy result. So the patient would have taken already this initial dose and two more dose of ceftazidime avibactam combination therapy. So that will improve immensely your diagnostic stewardship, and you can because you are able to detect the gene and initiate the Aztreonam combination therapy. But one thing I would like to add on, that blindly starting as empirical therapy, again increasing the resistance pattern to a greater extent. Okay, so you need to be sure whether your isolate is NDM or NDM co-producer with OXA or any other carbapenemase gene, and then only you should go for using this combination therapy.
Thank you. But we were doing the gene
Question is,
expert.
hello.
Yes.
Hello. So my
Yes.
question is, what will be the flow of the test? Like we got CRE
You got,
and then doing the gene expert first, and if we get only NDM, then ceftazidime
No,
avibactam
see,
plain will
first thing,
suffice.
by from Bytech you are getting the CR information, right?
Yes.
So so that is your initial criteria, that your isolate should be CRE by getting your N405 or 406 result. So if any one or more than one carbapenem are resistant, then you call it as a CR, and you further include those isolate for your study. The initial methodology, as I told before, that 3 different steps that you have to perform: CZA disk diffusion, Aztreonam disk diffusion, and CZA Aztreonam Synergy by disk elution method. Okay, so you need to put up CZA and Aztreonam disk diffusion using a single plate, and in the same plate you can put up the Synergy also in half of the plate. So in half of the plate, CZA and Aztreonam disk. In half of the plate, you can put a modified e-test and disk method. One CZA e-test and one disk. So using a single plate, you'll get to know all 3 informations actually. CZA AST result, your AT AST result, and your AT Synergy information. And in parallel, you have to do disk elution method, CZA ATM disk elution method. Okay, now this carbapenem, as you said, we kept it optional because we don't want to give more burden to the center, but we are encouraging that you should perform the carbapenemase disk. So you have to do the carbapenemase in parallel to your disk susceptibility disk diffusion and putting up the Synergy test. So in parallel, if you do the carbapenem detection method either by MC-MESIM or your gene detection by PCR result. So at the end of day 3, at day 3, you'll be getting the whole lot of all information in your hand: your CZA susceptibility, Aztreonam susceptibility, your ATM CZA Synergy result by 2 different methods. The must one is the disk elution, and the other one, any one of the other method which you can put, either modified e-test disk or strip stacking or cross strip method. Okay, and your CRE detection information.
So apart from this study, let us say I don't have illusion setup right now. I get CRE, then I do the gene expert, and if I get only NDM, then can the directly ceftazidime avibactam can be started to the patient?
See, as per our study protocol, you need to perform broad disk elution test for Synergy demonstration, because that is a must, compulsory. Okay.
So illusion or disk diffusion is must.
Yeah. Even the patient-wise mere detection of NDM doesn't you can't start Aztreonam as a combination in the patient. In patient treatment also, you must do some methodology of synergy testing, must demonstrate synergy, and then only use that combination. So even just an NDM detection and using that combination in patient is also not, but is not recommended. So that was patient's management. Study though, it's compulsory to do.
Sir, one question.
Sir, can we have size specifications for all these four screw cap glass tubes with flat bottom? Any supplier or something which can have uniformity in the study?
Yes. Ketan, do you know?
We'll share that. I'll share that in the group. Some dealers who have just some specifications.
Yeah, I think that will give us a uniformity, sir, because if we may not get the tubes or may get larger tubes. Because larger tubes may also increase the chance of contamination with small amount of media in that.
A minimum volume of the tube must be 10 ml with a screw cap. That is the minimum requirement. It should be autoclavable because you have to
Absolutely.
reuse it on multiple isolates. So these are the two
Absolutely.
base requirement. I will share the group. Tasan has those screw ones, but I'll share the group, details in the groups.
Sure, sir. Thank you so much, sir.
Sir, sir, this is from 174.
Yes, ma'am.
Sir, we have a doubt that any meropenem or imipenem like penem drugs, if it is resistant, you have to go for CR. But in Vitec, we are getting inconsistent notes, sir.
Those like you're telling that if imipenem is resistant and meropenem is changed by AES as resistant.
Yes, sir.
You have to include those because anyway your one carbapenem is coming resistant. The report of the other one is changed by AES. So for our definition, it is one carbapenem resistant. So if you're any carbapenem, imipenem coming resistant, you have to include that isolate in the study.
If imipenem is sensitive and meropenem is AES inconsistent, showing R, then sir?
I think this is a rare scenario where imipenem susceptible and still meropenem is changed to R by AES. But I think we can include that isolate also. So it's a tough call. What you say, Partha?
Yeah. Actually, most of the scenario you may get in very rare occasion you may get only artapenem resistant of MIC more than 8 and your imipenem meropenem sensitive. That may happen in case of ESBL hyperproduction or MCV hyperproduction or plain OXA 48 production.
But ma'am is asking a different question. Ma'am is asking that.
If it is imipenem sensitive and your AES modified meropenem MIC as resistant, then whether we should include those or not. Yeah, we can include.
We'll include.
I think we can include those.
Yes.
Okay.
It's a rare scenario that,
that
all three carbapenems coming and still AES modify one of them as R. It's a very rare scenario, but still include we will include that in our study.
Okay, sir. Thank you.
Sir, one thing we had observed that Aztreonam disc diffusion and Ceftazidime avibactam disc diffusion, when we place two nearer, like 20 mm apart, so we found some zone of inhibition between these two discs. So is it it has any significance, sir, in our study?
No, this qualitative synergy. This is what old methods of synergy testing were there. When we used to place two discs in substrate close to an inducer and ghost zone or of inhibition used to occur. This is a very qualitative method of synergy demonstration, not to be taken significantly because mere demonstration of synergy is not significant. You must test a method which demonstrates the drug to be susceptible at a breakpoint level so that it can be used therapeutically. So those old methods of placing this close and getting a ghost zone in between it qualitatively indicates a synergy, but need not be taken account as synergy in study as well as in therapeutic practices.
Okay, thank you, sir.
Sir, there is another isolate from 174, sir. Here we are getting the imipenem and meropenem sensitive, but ARTA is I immediate.
In our study, all those isolates can be included in the analysis.
Even I also?
Yes.
Okay. Okay.
Good afternoon, sir. I have a doubt. Sir, for the urinary isolates of enterobacterials, do we have to separately test for Aztreonam as in Vitec? The N235 panel does not have Aztreonam for urinary isolates.
Yes, you have to test it. Even I believe N405 is not having Aztreonam also. So all those where you use N405, you must test Aztreonam separately. Aztreonam disc diffusion is compulsory, irrespective of use 235, 405, and 406. Aztreonam disc diffusion you have to perform, so you have to procure your Aztreonam discs.
Okay, thank you so much, sir.
Okay, if you don't have any further doubts, then I'll Saravanan, are you there with us?
Yes, sir.
Just open the Excel sheet. Any other center who has joined us later and hasn't marked the attendance, I'll request those centers to please let us know that you have attended the discussion. Saravanan, you say Excel sheet now.
Yes, sir.
The attendance sheet. Do we have any center who has joined late, have missed the attendance part?
VMR 32 joined later, sir, and
Kailash Institute.
Mark there. Can we have a response from them?
Yes. VMR 32 is there.
32. Okay, ma'am. So, Saravanan, mark VMR 32.
Mark, sir.
Yes, sir. Mark.
129. has also joined late 129.
129.
Yes, ma'am. This person.
Yes. Anyone else?
28 is also joined.
VMR 54, sir.
54 is there. 54 you marked. Dr. Sazad is
28.
there. 28 we have marked, ma'am, already.
Yeah.
Ma'am, you have to fill the Google form for.
We have already done it, Dr. Ketan. On 30th, I've submitted it.
Okay, let us check it once. So, Stacey, you check it once.
Yeah.
Ma'am is telling that she has already
Yeah, I've
submitted.
actually interacted with Miss Mrunal also.
Okay, then we'll recheck ours and
Yeah, please recheck. For 3 studies, sub-studies we have enrolled.
Yes, we'll do it.
Yeah.
Anyone else? Have we missed anyone? We didn't get any response from Venkateswara Institute, Tirupati. Then Kamaini Academy, go down, Sarvanam. 2 institutes. Then we didn't get any reply from, I think, Kalinga Institute. Kalinga, someone has responded. No, this we have added separately.
Yes.
Oh, we have. So
I'm there.
Yeah.
VMR 120.
And Chittaranjan National Cancer Institute. So 3 institutes have they have joined. Okay. So any institute which has additionally joined and whose name is not in the Excel so far?
Sir, VMR 28, we have received the form now.
Yeah, 28, 62, 31. Yeah, okay, fine. That's it. Even 62 and 31, if the centers representative are there, I'll request you to please fill the Excel now, because if you're willing to participate in this, now you have the discussion with us. So and any other center who has attended the meeting and we have not told your name, or then you can respond. We'll include you. Oh, I think nothing. So that's it from our end. Then we'll reach back to you soon. We'll provide you with a Google form, this group, and you can let us know your plans on procuring these things. Have you already procured and are ready to start, or you are on the way of procuring? What would be the time lag we expect you to have a procurement and begin the testing? We'll maybe create a WhatsApp group, especially for this subgroup study. We'll throw a Google form. We'll like to know the response from these institutes, that what's the lag we expect, because we expect the study to begin by 1st of May. If those centers we have already procured it, may begin it right away. And just let us know that you are going to start it. At least other institutes, once we know how's that lag, we'll have a planning on that. We expect the study among all these subgroup institutes to start by 1st of May. This is usually our, we're thinking the mind as a cutoff, but still we can accommodate you once we'll have a reason for why the delay is happening and all. So the next thing to go is we'll have a WhatsApp group dedicated for group, and we'll give you a Google form to respond to see the progress, what lag we are expecting in your institute to proceed with this group study. Okay, so that's all for today. And if you don't have any other doubt regarding the protocol or regarding the procurement and all, I think we can depart from this.
Ketan, that protocol we can share with them.
Yes, we'll share the protocol with them in short while. Okay.
Sir, one thing is that IRB permission or IEC permission, does it require for this our study?
No, from our end, there is no requirement of as such. The only request is if any participating institute is going to include or make any faculty as a coordinator of this subgroup study who is not currently a part of the VMR phase 2 study, we would like you to resubmit the agreement form with the new person's name included in it. This is the only requirement for you. No IC compulsory and nothing as such in our case. If you have already made some person who is already coordinator or investigator in the VMR phase 2 study, nothing to do as such for this subgroup study.
Okay, thank you, sir.
Dr. Ketan, one question from VMR 15, Breach Candy Hospital.
Yes,
how we are supposed to submit the results, like on the IBAR platform, or it will be
no, ma'am, that we have shown.
Google sheet.
We'll share a Google spreadsheet. Yeah, it will be in the center specific Google spreadsheet. Each center will be having their own Google spreadsheet. With those, I will try to make drop downs as much as possible for the ease of entry. You will not type everything, but individualized institute specific Google spreadsheet is the method of entry.
Okay, and all the basic rules of microbiology, like first isolate from that patient, that will be applicable for this.
No, not it's this study is for all isolate based study. Preferably repeat multiple isolate from a same patient. If you can track back, no need to retest for it.
Okay.
But though no first isolate rule applies for this study, it's an all isolate based study.
Okay. And the For the study, the disk diffusion method is compulsory. In addition to that, the method which we are currently using, we can submit those results also.
Yes, sure. All options will be given in the spreadsheet.
Okay.
Yes.
Thank you.
Thank you.
So this will be sharing with you. I think my screen is visible.
Yes.
Yeah. So this is the Google spreadsheet. We'll add the drop down and share with you.
Yes. We'll create it for individual centers. We don't want all the centers to keep entering in the same Google spreadsheet. So what we'll do is we'll create individual spreadsheet for each center so that you'll have your data compiled up in your spreadsheet only. So it would be individual institute specific spreadsheet. So we'll create that and then we'll share each spreadsheet with you. That will be done shortly, maybe another 1 or 2 days.
Sir, can you share the PPT for the presentation so it will help us?
We'll definitely share. We'll try to share the video for this presentation also, so that.
Dr. Ketan, can my colleagues be added to this VAMR sub-study? I'm requesting for this with Dr. Partha.
Yeah, that is what I'm telling you, ma'am, that any new faculty or a senior resident who you want, preferably faculty who you want to be the coordinator for these subgroup studies, and they are not already a part of VMR phase 2, then they can definitely lead this subgroup study. The only thing you have to do is you have to resubmit your form. You remember you have submitted an agreement form to us with all the signatures of the investigators. The same need to be resubmitted with a new name included in it. That's it.
No, it's the same group who is going to be there for the VMR sub-study because mine is a specialty center, cardiac center. I don't have more faculty here. The same group was a part of VMR 1 will be a part of VMR 2.
You can definitely do it.
Yeah.
Definitely.
I need these people to be in the group so that I am totally busy with so many things.
Okay, WhatsApp groups. Okay,
WhatsApp group. Yeah.
You just post the message in the
I've already shared their numbers. Dr. Partha need to add it. Whoever is the admin.
Okay, we'll do that. We'll do that, ma'am.
Yeah. Thank you.
Okay. Okay, that's it then. Then we'll close this meeting and hope we'll create a WhatsApp group so that we'll be in closed loop, not in the main group. Discussions would happen in the closed loop for these centers. Okay, so for the time being, thank you so much for being here, attending this meeting.
Thank you, Dr. Ketan. Thank you, Dr. Partha.
Thank you.
Thank you.